Meeting to order. Roll call.
Dutchess County, Nicholas Trio here. Dave Villante. Here. Joan Siebert. Tim Murphy. Matthew Nolan. Pete Chanella. Dee Seikendorf. Guy Carpicio. Orange County, Joan Cheney. Ben Conquest. Eileen Mancuso, Andrew Lamarca, Israel Knobloch, Terry Barbie, Frank Cass Knight, Michael Bigg. Putnam County, Robert Cuomo.
Here.
David Jacobson.
Here.
Matthew Bondi.
Here.
Albert Jacobs. Rockland County, Kim Lippis.
Here.
Nick Rusiecki.
Here.
Michael Murphy.
Here.
Desiree Leone. Len Albin.
Here.
Deborah Stewart. Bernice Garotti. BJ Leidner.
Here.
Sullivan County, Abby Bachman.
Here.
Greg Tavermina.
Here.
Neil Medaw. Heidi Stack. Mike Bruce. Mark Strauss.
Here.
Ulster County, Rich Parrish.
Here.
Kelly Nelson. Rich Mullerly. Dorothy Balin.
Here.
Lisa Servino.
Here.
We have 16 in attendance.
And that's a quorum?
Yes. Oh, Joan
Joan
Siebert,
Siebert.
okay, then it's 17.
Okay. All right. Minutes. One correction on page 43, line 14. It says the district program. It's the DSRIP, DSRIP program. And that's the state health care program. Right. Any other additions or corrections to the minutes? If not, motion's in order.
Motion to accept the minutes.
Second.
Okay. Presence report, letters. New alternates for the Sullivan County EMS Council are Mike Bruce and Mark Strauss. Please send any future correspondence to my email. Thank you, Neil Maduga. All right. There's a, did I butcher that?
Meadow.
Meadow?
Meadow.
Okay, meadow, like a meadow. All right. All right. 2018 meeting dates are listed.
Hold on to
Oh,
those.
okay.
We have two in question on that. September 19th, which we have listed there, is
Okay, two in question. September 19th is Yom Kippur, so we need to revisit that. And I think in the minutes, we discussed that we would hold off until we saw when the state meeting was going to be, so that we could discuss things following the state meeting, because that messed up our last meeting. We had it before the state because of that, so I remember reading in the minutes that to hold off on that schedule till we got the state schedule.
my concern is that we have to put in a schedule for the room.
For the room.
So if we had a potential date, we could change it if it's available or not. But usually, even the last one, if the state meeting is that day, it would be over that Wednesday.
And we'd come rushing back from it.
Yeah.
Yep.
We've done that
All right.
before.
So, for Wednesday the 19th,
It's September.
any recommendations for a different date in September?
Well, either a week early or a week late.
What's that, Karen?
September 26th?
Go to the 26th, anybody
Is that a
have?
holiday? All right, let's, yeah, you guys.
It's okay.
Okay, 26th, okay. And then Wednesday, the 21st, is the day before Thanksgiving.
Yeah, that has to be changed.
That's gonna be a hard one. There may be traffic getting there.
I'll be cooking, so.
Yeah,
What do you get? What are you looking for?
I won't be.
Why don't we, we're about the 28th.
Go to 28th?
Right, I mean, that's what
Okay.
we did this time around, so,
Yeah.
yeah.
Okay.
Yep.
And you're gonna talk about that. We have a note from Dee Segendorf. Karen, unfortunately, I will not be able to attend this evening's meeting. Hopefully you have been notified that Tim Murphy's son, Michael, passed away suddenly on Sunday. Only 28 years old, who was involved in EMS from an early age, following his dad's footsteps. I'll be going to the calling hours this evening. Please pass this information on to your office staff in case they are not aware. Sorry to cancel out, but have known Tim for many years. Best wishes to all for the upcoming holidays, and our sympathies to Tim. Tim is a member of the council, on the loss of his son.
We've been very involved in Dutchess County, in this task force and a lot of things, so we're probably by a lot of the members. and not-
Okay? All right. And we have a letter from the state to Rich Parish, Hudson Valley Remsco. This is to inform you that your representative to the New York State Emergency Medical Services Council, Kim Lippis, fourth term will be expiring on December 31st, 2017, and a new delegate must be chosen. We just had a executive committee meeting and discussed this with Kim, and Kim seems to think that she just got her letter extending her appointment, so we're going to hold off, and Kim's going to check on the dates on the letter before we do anything. But if we have to reappoint somebody, anybody that's interested in this, let myself or Bill know, because the process takes at least 6 months to get started. So if Kim is sunsetting, then we need to be working on it, but hopefully she's not. So as soon as we hear from Kim, we'll proceed with this. All right? Any other, well, that's it for the President's report. Treasurer's report.
So since the last meeting, we wrote 27 checks totaling about $11,000. Rent and healthcare is our top expense. Details are here if anyone wants to see them. We deposited our New York State voucher for $52,000. There's a quarterly council for $3,756 was billed and paid. We have $126 refund from the U.S. Treasury for overpayment of payroll taxes. Transferred $36,000 last quarter to payroll, and we got paid for CLI.
For what?
education
I'm
class.
sorry, next what?
CLI education class, $1,620. About it. Our program agency currently is at, our total account balance is $228,366.
Any questions of the treasurer? Motion's in order, accept his report.
Second.
Second. All in favor?
Aye.
Abstained? Nays? Carried. All right, regional staff.
Okay, we're back at full staff. Karen is back. She was out on surgery for a couple of weeks. Our naloxone shipments are coming regularly. We seem to have a decent amount of supply. The only thing is the new shipment is a 4 milligram dose rather than the 2 milligram that we have, and it's not the one that you have to assemble. So it's a single unit and just hit the plunger and it issues the naloxone. So if you do get that as a replacement, do an in-service on it so that your people are not trying it out to see if it works, okay?
Bill, are there trainers for that
No,
particular
there's no
type of-
trainers available that we have seen as of yet.
Mr. Murphy?
You can order duds from Adapt Pharmaceutical, they will send trainers. You have to go to their website and contact them directly. It is the 4 milligram dose in the 0.1 ml. It's much easier to use for anybody, it's like a bottle of Afrin. And since what we see most of the time now is that it's taking 4 milligrams to get people to even start respiring. The question of initially using the 4 milligram dose is moot right now, so that's why it got pushed out. Finally got approved by New York State. We were trying to get it for the past 2 years. This was just so much easier for public safety personnel to use. So I'm glad that it's finally making its way into the pipeline. But the company will send out the trainers.
And who's the,
www.adaptpharma.com.
Adapt?
Adapt Pharma. ADAPTPHARMA.
Good. I'll get on it right away. I'm doing Narcan training next week. I don't know if I'll get it in time, but...
They're nice folks. They're out of Trexeltown, Pennsylvania, or whatever, so.
Yeah, okay.
Okay, thanks, Mike. Go ahead,
Okay.
Mike. I'm
Our
sorry.
collaborative rollout, all the providers have been completed. The physicians, we still have a few stragglers. Our biggest opponent right now is Vassar Hospital. We're trying to get those people up to date. There's been no update that I have gotten on the BLS protocols. I know they went out to EMS for Children and Trauma to come back, and hopefully they'll be available to be voted on in the January SEMSCO meeting. Mission Lifeline put out a couple of things from AHA. One of the things is they lowered the hypertension threshold for blood pressure to 130/80 from 140/90. And they also put out an app that you can access on AHA guidelines for your mobile device that will download all your AHA guidelines, and you can use the app if you're interested in that. And they're still working to decrease the first medical contact to balloon time. That's what they're trying to track at this point. The REMAC has issued an advisory. I'm sure Dr. Pappas will go over that. The New York State Vital Signs Conference was held in Rochester in October. I did not attend it, so if anybody wants to do an update on it, that would be good. The only thing I know that came out of it is that they're supposedly going to reduce the CME recertification requirements for all levels of EMS. Do you have an update on that right now?
I did not attend that. I know Dave Grass from Mobile Life did. I don't know if he gave a, but they're reducing the hours, but yeah, I don't have the specifics.
Yeah, I haven't seen anything come out officially.
Okay.
So I went up there for that, and the state is
Perfect.
reducing the hours. The EMT hours are going to go down, as well as the paramedic hours, but not as much as the EMT hours. It's not all confirmed yet. The information will come out in the spring, including new sheets. They are going to also change the actual physical skills that need to be done as well for the skills checklists. But nothing is written in stone yet. That stuff will come out in the spring. When it comes out, we'll know, and we'll disseminate it to everybody.
I think the big change that Dave mentioned to me that they have concerns about is it used to be the training coordinator could sign off on the skills, and now it has to be the medical physician.
Some of that stuff is sort of still up in the air.
It's still in the air? Okay.
And so as soon as that stuff comes out for sure, then we'll disseminate it appropriately.
Okay.
Dave, did they give a reason why they reduced them?
No.
I
Okay.
believe it's to mirror the national standards would change, because what the state is trying to do is, and it has been since the past curriculums, is align itself more with National Registry.
Thank you.
At the beginning of November, we had our annual audit. We haven't gotten anything back from it. but we should have our draft document shortly. And for some reason, the IRS has chosen to do a examination of our compliance with our 401K for the three of us in the office. So we're working on that with them. The federal grant for the EMS for children is coming due again, and they have sent out a survey, and I think we have about 40 agencies in our area that were asked to answer questions on this survey. So if you are contacted for this survey, please respond. That's a separate grant that we get from the federal government that goes to the Bureau of EMS, and that's what they fund their children's program with up there. So if you're one of the agencies, please respond to the grant request. And that's all I have.
Any questions, Bill? Nope. Okay. QAQI, Jeff?
We've been actually busy with the EPCR system. The New York State Supplemental Data Dictionary was pushed out to the vendors for the state requested changes. Those changes have been made. They are in the process of creating the 3.40 bridge for New York State. Theoretically, 60 days. So probably sometime in the first quarter of 2018, and they are working on a plan to pull the new data. There are vendors that have been 3.40 compliant for quite some time, and a lot of regions in the state have their own regional bridge. So it's going to be an issue as far as uploading the data that New York State hasn't been seeing. So it's going to be a rollout. We have had a regional bridge for the last year and a half that has seen little activity simply because we didn't want to move anybody over there until they worked all the bugs out. Recently, we did move Olive First Aid into that simply because it's 20 calls a month, give or take. So it's much easier to check the rules, make sure everything validates the way it's supposed to, rather than taking an agency that runs hundreds of calls a month and have to debug that. So far, we have seen no issues with that, so we are hopeful that the rules actually work the way they're supposed to, and we'll see how well it maps in the first quarter. Narcan shipments, the requests for replacement Narcan have actually dropped in the last quarter, not nearly the requests that we had been getting. And that's about it since last time.
Okay. Can we get a report by county of Narcan usage?
Well, yeah,
Okay.
sure.
And then also, coordinators at one point were supposed to be able to get access
No,
to the Nemesis Bridge.
no.
I thought that was supposed
That's
to.
what Mike Saylor said when he came here for the EPCR meeting.
That is what Mike said, but he had to retract that.
Okay, how can we get reports on EPCRs out to the counties?
What would you like? Give me the list of reports that you would like, we'll generate and send them.
Okay. We'll have the coordinators look at that and come up with that request. All right. Any other questions of Jeff? If not, all right. Medical Director.
So, the last REMAC, there were a bunch of things that we discussed, and also, well, actually the most important thing was we sent out an advisory. When did it go out? 3 weeks ago?
Yes.
About diversion within the Hudson Valley. Probably most of you read it, maybe, hopefully, I don't know. But effectively, we got rid of general diversion in the Hudson Valley. There's really very little medical evidence or studies that shows that it makes a big difference. Number one, it certainly inconveniences the EMS community, and usually those patients that get diverted end up getting transferred at a later point to where they get their care that they were trying to go to begin with. So it's sort of an inefficient policy that was designed to help hospitals when they were overloaded, but the problem is most of the hospitals are overloaded because they're not doing effective measures within their facility to handle the volume that they're dealing with from the emergency department. So, and the hospitals that have actually done stuff have made significant changes and frequently can overcome their internal problems that cause them to go on general diversion. An example, I guess, actually within our system is Orange Regional, who last year was having diversion issues. They made some significant changes within their department and within the hospital, and their diversion problems went away. So general diversion is essentially over. That being said, there still is specialty diversion or equipment failure. I mean, every once in a while, hospitals have stuff that breaks, and then it doesn't make any sense to bring patients there. So that is going into effect as December 1st. The important thing about the other sort of thing that we attached to that is there's a web-based server. I think we discussed this the last REMSCO, maybe? I don't remember. But there's a web-based server that's based in Westchester County that includes all the hospitals within the Hudson Valley region. The only one, there was a question whether Sharon was on there, right? And we can probably get them added. That lists everybody's diversion status, and hopefully we'll get compliance. We don't really have a lot of teeth in the issue, but if the hospitals are going on specialty diversion, this would be a very effective way for everybody to know at once, instantly, and you can log in from your phone, and dispatching PSAPs can log in. So it would be very easy for everybody to know who's on diversion when, and it also serves as a tracking tool. That's why it was designed way back when in Westchester. So we're hopeful the hospitals will sign on to it when they go on diversion, and it'll be an effective means of general communication. The other benefit of that is in the event of an MCI, it serves as an easy way to list your availability of how many beds you have on a web-based server that everyone can see if there's a really big incident. That being said, some of the hospitals haven't logged in since 2003, so we're hopeful we'll be able to get everybody to start using that as a means to communicate. So that was the advisory. Dr.
Papish, on the advisory, are the PSAPs logging on the 911 centers?
So I don't have there's a general login that anybody can access. It's with a general, it's WCEMS. WCEMS is their, sign on and password. I think that's it.
Yep.
Don't quote me. Delete. No. And so I don't know if there's a way to track whether the PSAPs are logging on. I mean, it's a perfect, easy system.
Because once you've logged on, like I log on from my facility, I get an email every time a hospital goes on diversion. If their CAT scan's down, they can't do strokes, that type of. So I know that all the time. So if they were signed on, they would be getting that.
If they were, I think you need an account though. Like you log in through your account, right? And then
They would get an account.
For some reason, I was Catskill. Catskill Regional. Whenever they had problems, I get an email. So it's not a perfect system. But yeah, I don't know. We could talk to Mike Bulk about generating accounts for them so that then they would get notifications. Because there is an enhanced ability to get notifications within the system.
Quick question, Dr. Papish, with regards to that, like if it's going to be the whole region, like Rockland County PSAP doesn't really need to know if Vassar is going on diversion. Is there a way that if, let's say, Maya or USAM or something like that was to go on CAT scan diversion because of CAT scan?
It would send them an email? That's what we're talking about.
Send them, no, but in other words, so it's selective to the county if that hospital is responding and putting thing on up front, hey, we're out on CAT scan. Now that can go to like 44 Control or to the various police departments that dispatch agencies.
It's all on one screen. Like if you log in, have you logged into it ever?
No, I haven't.
It's really, I mean, literally all the hospitals are on one page. We don't have enough hospitals for it to go off, so you don't even have to scroll down. You can see every hospital in the system, and it lists their status. So they can just leave the page open on their computer. I don't know what the logout time is, but you can just instantly, if you're ever curious, you can just pop open the page and it lists everything right there. I don't know, it doesn't send out like Pages or text. It doesn't have that ability, but it does send out emails. And so what we were talking about is it would be nice if all the PSAPs, the individual PSAPs, had accounts, which I don't know if this is feasible, but it probably is. Just the same as what we get, they could get an email when their local hospital is out. Of course, email is like, you know, I'm hopeful they have their email logged in at the same time. It's not really an efficient way of notification. But the reality is if you just have the screen open, the web page open, you can see all the hospital status instantly. Any other questions about it? So what we have to do starting when December 1st is look at it, see who's not logging in, find out who the resource at whatever hospital it is, and let them know that this is going on if they didn't get the advisory, which, I mean, the reality is those advisories get mailed out to the hospitals, but do they filter down to the people that are actually, you know, the ones clicking the mouse? So that was the advisory. The other things that we discussed at the last REMAC meeting, there's a PI project that's going on via the RTAC to look at oxygen use in trauma patients. Well, there's a general trend. Everybody, if you're reading the literature, and it's sort of a trend in general to use less oxygen because we realize a lot of patients don't need it. There was a big study that came out that MIs don't really benefit from extra oxygen if they're not hypoxic to begin with. And there's obviously a long-standing trend to decrease oxygen utilization in COPD patients. So there seems to be a trend in medical patients decreasing oxygen when not necessary. However, that doesn't seem to apply to the trauma patient, to the knowledge that we have at this point. Patients that are in early shock still benefit, to the best that we know, from extra supplemental oxygen. And so I guess it was noticed by some of the trauma surgeons that there's an abundance of people that are brought in as trauma patients to the trauma centers not on oxygen, and they had concerns about that, so they've started to do a study, and specifically in patients with head injuries, because head injuries, hypoxia during an episode of head injury doubles mortality. And so they're starting a PI project based on that, so something to bring back to your squads, trauma patients, head injury patients, make sure they're on oxygen so you don't glaringly show up in the study. The last thing, let's see, Universal Notification Tool. The Universal Hospital Notification Tool. Are you going to talk about that, Dave? Notification?
Sure.
We can talk about it later. The last thing from the REMAC meeting, there was a big talk about it, but coming up with a uniform notification, a means of notifying hospitals. One of the things that's frustrating, I think, for EMS providers is every hospital that has a trauma center is got sort of a notification that they expect, I guess, or they want. You know, Westchester is always pushing the NVI, TTT.
Wait.
NVI, TTT. Method of notification, and other hospitals have other requests, and so we'll talk about later on, but coming up with a universal notification that would make it easier for providers that need a tool to adequately and efficiently relay what they're bringing in would be beneficial. And the last thing that we talked about is just the DMAT teams. Dr. Larson made a plea that anybody that's interested in being a DMAT member, go look on the USA Jobs website. I guess the DMAT teams are losing members or have lost a lot of members and haven't replaced them. So it's significant.
The hiring is just open. The only thing currently is team leader and deputy team leader that's open for the areas. Hopefully positions in medics will come next. It will be on USA Jobs. If anybody's interested, reach out to the team closest to them. Because what I do for the team from Rockland is I'll take the name and the resume of the person, and as soon as I see it posted, because it has limited posting, I'll send it out to prompt them. If you're interested in it, you can go on usajobs.gov. You can set up your own account, your own profile. I would not tell you to put your resume or CV in until you get the description, make sure you're hitting all the points, because the people that are evaluating it don't know anything about medicine, and they just check off the boxes, so if you don't say the word they're saying, you're not going to get on a cert list. It's a critical fail. I just came back from Puerto Rico, was in Texas for 2 weeks also. There's a shortage, but the hiring process is crazy. I think the last person we hired on our team was like 3 years ago, and we have major shortages.
So, something to bring back to your crews. That's all I got.
Any questions, Dr. Papish? If not, okay, committee, training, you're Dave.
Great, I'll just go right off of what Papish was talking about with the radio reporting. We are looking at a standardized report across the region for the call-in, for the radio report, and additionally the bedside report. And so we would come up with a standardized version at the moment. It's gone out for review to the REMAC. We sent it out to a number of individuals at one of the local conferences in Dutchess, got some feedback. Dr. Berkowitz has looked at it with his group, so Dr. Berkowitz, Dr. Papish, myself, Dr. Arshad, and a couple others on a committee to review that to come up with a standardized approach at the regional level that the region agrees with. The impetus of this was not only from different trauma centers requiring different reports, but then cardiac centers and stroke centers, and every individual hospital wants their own report. We wanted a standardized one from the region that we could send out, say this is sort of a good model to use. This is not the bedside report. That's a whole different thing. Dr. Berkowitz is also looking at the MIST report for that. And so we're going to end up making a recommendation to the region for a radio report and a bedside report that the region endorses. That'll be coming up. The CME program.
I'm sorry, the what?
CME program hours may be changing things again, Mike, for clarification with that on what those are. As soon as those come out, we'll let the group know what those are. Also, the change in age for EMT to be able to certify is moving from 18 to 17. When that happens, we'll also let the group know. And the training committee is also looking at having a regional approach to an RSI standardized training program from the region at the regional level versus at the agency level. And as that rolls out, we'll provide that as well.
Any update on the CLI program and results?
So we did hold out. I think I had relayed it at the last meeting.
Yep.
It went really well.
But they just took the test.
Yeah, I don't know the results. Most of the people had taken the test. There were a few that are going to be taking the test in December. And as far as I know, that was a success. And we're going to look at changing that a little bit in the future to accommodate changes in education that come about with flipped classrooms and training of millennials and just the difference in training as it's moving forward.
Okay. Any questions of Dave? REMAC, you already gave that. That Transportation Committee, Glenn, anything?
No report.
All right. Public information, nothing? Albie?
The most interesting committee in this organization. All right, for your interest, we have some bills that are in the Assembly. Nothing going to the Senate yet, but these are interesting. At the Assembly, they're pushing to have insurance protocols for ambulance services, that there must be a minimum amount of medical malpractice insurance for any service that applies for a CON or possesses a CON. And we basically now have those minimums in place anyway. A minimum of $1 million per occurrence and $3 million for all occurrences per policy year. Next. Bill number A05626 out of the Assembly. Nothing yet going to the Senate. It authorizes the Commissioner of Health to extend the certification of any emergency medical technician, advanced emergency medical technician, or certified first responder who cannot become recertified due to illness or medical condition. So if one is unable to do it because they're either home ill, in a hospital, and it includes even their recovery, no matter how much time it takes to recover, it protects that person if they're unable to recert. We'll see about that. That was referred to Public Health Committee. Not legislative, but of interest, the FDA extends expiration dates for EMS drugs that are in short supply. You probably already know that, but this came down. If you need to know that list, I have some copies here for you. Of further interest, out of Sullivan County, you know, that's the one county in the southern part of our region, if you don't know. You can forget about us down there.
Wait a minute.
Our
Southern?
Our legislature has taken it upon themselves to pass a resolution that has gone up to the state level to have the governor's office push to find ways to recruit, retain, and protect the EMTs that are out in the field, the volunteers. Looking at possible tax benefits. So they actually passed a resolution that went upstairs, and it looks like that one particular administrator in our county is pushing to have other counties do that as well. If you recall, at the last meeting, we touched upon us being designated as an essential service, that at the state level, they're looking at doing something about it. It's slow to come. We had discussion about doing it from the bottom and working our way up. I did meet with Mr. Depew, who is our deputy county manager, very progressive. The name is known here in Orange County. He was a legislator and also supervisor for the town of Walker. Very EMS-minded, and he was very interested in that discussion I had with him about doing it through a resolution at the county level to declare us an essential service, and that I would go ahead to the county association of the state of New York and present it there and get other counties to also make that resolution and take it up to the state level. I mentioned last time also, but an article came out on the exposure of carfentanil amongst our first responders. Pennsylvania seems to be having their share of that exposure. It's a reminder that we must protect ourselves when we do overdose, to make sure that we wear our gloves and possible masks. And also in the state of Pennsylvania, a county in the state approved a tax rebate for volunteer EMTs and firefighters. So yes, they recognize that we are important out there. It may be slow coming, but at least people are starting to listen to the benefits of having EMTs and paramedics in our country. Thank you very much.
Okay. Any questions of Albie? Albie, at the last meeting, you mentioned that you're waiting for a mutual aid legal opinion.
Yes, I was waiting for that. Since you brought it up, there'll be no report from the Mutual Aid Tag Committee until that legal opinion from House Counsel comes down from the DOH.
Okay. And also, and I think you touched on it, you also mentioned of going to the Association of Counties, doing an essential services presentation, and it sounds like you're working on that
Yeah,
from
as I just
that level.
mentioned now, speaking to Mr. Depew, he liked it, and we're going to meet again to make that resolution, and we'll pass it. We'll bring it up at our Sullivan County legislature.
Very good. Thanks. Okay. EPCR. We have to change that. I still have Mr. Cuomo down as
I
the...
was getting ready for you to ask. I was prepared that you were going to ask me for the report.
Nothing.
You were good, you were good.
Yes. All right, community paramedicine here, Mike.
Why don't you mention that? Maya Cosmo and Rockland Paramedic Services received a grant from Montefiore Medical Center. We'll be starting a community paramedic program probably the 1st of February. It's designed to identify high-end utilization patients that frequently come into the ER, and also at-risk patients who have been discharged from the hospital. The workaround that we worked through with regard to Article 30 is that NIAC will have a patient navigator, which is going to be a mid-level provider, an NP or a PA that's medical control qualified. And instead of community paramedics going around with a route list, let's say, to visit this patient, this patient, this patient, and do that, they will get the call in from the patient if there's an individual problem, and if the navigator decides that they want to send a paramedic out to take a look at the patient, then the navigator will send that person out. So in essence, the paramedic is being dispatched to check on a patient. Just like we would be dispatched to evaluate a prisoner, dispatched to evaluate whoever, and it's being done so by a medical control person. With regard to this, the reason why this subcommittee was started here in the region is that there is been some motions to change Article 30 to include out of the emergency arena. That stalled last year. There seems to be some headway this year. The home care agencies and the Nurses Association originally objected with negotiations with Onion and Nicevera and state chiefs and Haney's to try and push that, overcome those burdens and get the legislation actually changed. But in the meantime, this workaround seems to be what we call the Article 30 workaround for now. One of the problems that community paramedic programs are facing is the ones that are being very successful and are preventing patients from going to the emergency department and being readmitted are actually having great patient satisfaction, great physician satisfaction, great patient satisfaction, but are being shut down because the hospitals are losing revenue.
Yep.
And the reason for that is that when the Affordable Care Act was first designed, along with all this district money that's been out there, the design was there would be bundle payment. So in other words, a hospital or a physician would get paid X amount of dollars to manage this patient. That didn't occur. Everybody's still on fee-for-service. So if you don't see the patient, you don't make any money. So if you're going to not send a patient to the emergency room, emergency department's going to lose money. So it's a double-edged sword right now that the patients and the healthcare providers are very happy that bean counters don't like it.
But also, Medicare and Medicaid both have, if you get readmitted with the same diagnosis within 30 days,
Penalty reduction, yeah, that's
you,
one of the
they
funding
eat that.
aspects of it.
Yeah.
Yeah, I mean, I think utilizing EMS to see the patients that have been discharged in the hospital is a real win-win financially for both services. I don't know I mean, there's definitely revenue loss from not getting those patients coming back to the ER for like, I'm not doing so well checks. But if you a huge percentage of the time, they end up getting admitted, and when they get admitted, then everybody loses money. I mean, the ambulance doesn't lose money, but we lose money. And so, I think it's this is going to go forward. It's just going to take time because there is, union opposition.
Any questions of Mike? Thanks, Mike. All right, State EMS, the next meeting is January, so no update on that. Right, Kim?
No.
All right. All right. All right, and we had the mutual aid update, so, from Almy. And the collaborative protocol rollout update. I don't think there's any discussion on that, is there?
There's nothing new.
Nothing?
Not what we talked
All
about.
right, the regional EMS task force, that has fell flat. The coordinators really not doing anything with it. I think we really need to look at it, where we're going in this region, and if nothing else, it'll have to fall on the executive committee. We need to start looking at things. How do we work together? How do we collaborate? It's a dirty word, but consolidation of services, units are not getting out. So we need to do something with that. Any expiring delegates or alternates?
Nope,
Nothing?
we're in good shape with that.
Okay, yes, Nick?
Did we hit 8E?
8?
Policy and Procedures Committee?
Yeah, I don't remember.
Oh, I'm sorry, I skipped right over. Greg, policy and procedures. Okay,
See, I knew that, that's why I said.
yeah. All right, I'm sorry, yeah, and I got to check along everything but that, but yeah, I did miss that. Okay. All right, under new business, we talked about the meeting, yes? All right, we talked about the meeting date, so that's resolved. For new business, I'd like to schedule the Lower Hudson Valley Hospital Mutual Aid Coordinating Entity for a presentation here in February. And what it is it's a group of all 31 hospitals in the region have signed on to provide mutual aid. It did get activated for the New Windsor incident to the point where I was at the command center, working at the command center. St. Luke's felt that they didn't need any other assistance because at the time they only got 12 patients, and we sat there and for 2 hours, nothing. As I left there, they got 8 walk-ins, and then by the end of the 24-hour tour, they wound up with 125 walk-ins. All right? So, excuse me?
It's lost revenue.
Yeah. All right.
Tell them to call 911.
This group, and we have actively assisted with mutual aid requests. We've staffed the air show for that. We're right now working with Westchester EMS, Westchester Airport to do a big exercise in May. That'll be a region-wide exercise. So it's a resource for the hospitals, and we have actively used it in a couple of areas. It's a way for EMS to get more involved in disaster emergency management. And I know Dr. Papish and I have had some discussions about this because there was some concerns. Some hospitals didn't get notified, so.
Well, we thought you guys didn't know that we were, we communicated with Orange County Emergency Services.
Yeah.
And they were on the radio with us. Yeah, okay, good. But we didn't think you knew that we were all ready.
Well, I know
Yeah.
NIAC put out a HICS level 1 to basically alert staff that there's a potential.
Yeah.
Yeah, what we do, and Mid-Hudson Regional, their rep got transferred, and, talking with Sharon, their rep got transferred, so we don't have a rep from them. So when we sent out the blast email that, hey guys, here's something potential happening, Mid-Hudson didn't get it, Vassar got it. They couldn't take them because they were on generator power. Nyack got back to us, yep, we're ready. St. Anthony's, we're ready. Orange Regional wasn't taking patients because Catskill Regional was without power and they were having generator issues, so, all right?
Really? All the same, that's
All-
so odd, right?
Yes, yeah,
Vassar was on generator.
yep, so, all right? So, but we're gonna schedule that for February, Bill and I've talked about it, and we'll bring that forward and let you know what that organization's about. All right, and what we can do as EMS. Dr. Larson is a strong proponent of it. He sits on our advisory committee, and he is setting the same meeting up with Westchester Med for that, okay? Any other new business? Nick?
Have a motion, or seconded motion from the executive committee